So I thought I'd kind of explain a little bit about what acute oncology is and what it isn't, to go over some acute presentations of cancer to the acute take, and then just to kind of go over some newer and older drugs and side effects towards the end. So the importance of acute oncology. So the main reason acute oncology services exist is to promote education, awareness, and early access to specialist oncology input, as well as trying to find and foster a more integrated way of working between oncology and the acute specialities within any hospital trust. But essentially, it's about the right patient, the right treatment and care at the right time. And this is obviously overstating the point, because I don't think anyone would refer this, but we do quite often get referrals to acute oncology just because it ticks an easy referral box in that someone's had cancer treatment within the last 28 days. But it's kind of a reminder of the pragmatism that's also required. I mean, quite frankly, I would not accept anyone with that ECG just because they had a TKI 3 weeks ago. Okay, so the birth of acute oncology. So acute oncology in itself is becoming a speciality, much in the same way that acute and internal medicine has done. So acute oncology really came out of 3 key documents. Each one feeds into the next. So the first was the NCPOD report, for better or worse, from 2008. And that informed this document, the National Chemotherapy Advisory Group's guidance for ensuring quality and safety in the delivery of systemic anti-cancer treatments. And that evolved into what became the very first edition of the Manual for Cancer Services, which also sets out the remit, the role and the funding for acute oncology. A lot of this will be quite dry, going through facts and figures. If anyone wants to chip in at any points with their own experiences of acute oncology and the evolution of it, I mean, please do. It's harder for me to see because I can't see chat box or anyone with hands up, but please just speak if you want to say something. But if we go back to the NCPOD report, for better for worse, so this looked at a snapshot of hospital admissions over 3 months in 2006, so June to August. In hospitals in the UK. So during this period, there were 55,710 deaths across all inpatients from any cause. Surprisingly, 2% of these were patients within 30 days of systemic anti-cancer treatment and represented 1,044 deaths. During the same period across the UK, 47,050 chemotherapy treatments were given. So that's individual treatments, not individual patients. And obviously some of those treatments will be within the same patient when you consider many of our chemotherapy regimens are given 3 weekly. They went back through hospital records and had a full data set on 546 of the patients who died within 30 days of receiving anti-cancer therapy. Okay, so looking at this, and this was, I remember reading this report whilst applying for academic foundation program, knowing that I wanted to be an oncologist. 14% of patients represented in those 500 odd patients were having treatment for curative cancer. So these are people that we could have cured with chemotherapy or multimodality treatment who essentially died because of the treatment that they had. And that really resonated with me. So, and obviously the other 86% of patients in the study were having palliative treatment. I think the next 2 points kind of really forced us to look at ourselves and how we did things as oncologists. So 45% of patients who died were receiving second or subsequent line therapy. And back at the time of this audit, it really was a case of diminishing returns. We had cytotoxic chemotherapy and nothing else. And obviously you give your best treatments first. So the expected response rate or impact on progression-free survival or overall survival for second and subsequent line therapies is really small. 21.
When you say 14% were died because of the treatment, do you know that?
Things like neutropenic sepsis, absolutely. We, as we probably all know, weren't very good at A, picking this up, B, managing it quickly, or you know, or C, kind of having good protocols for what to do.
Right.
if you look at the patients who died within 30 days of treatment, 21% of them had a performance status of 3 or 4. So that's essentially a performance status of 3 is basically chair-bound, a performance status of 4 is basically bed-bound. So they were severely debilitated. And in all cases, the independent assessor felt that 19% of treatments were inappropriate, and most of those will be the performance status 3 or 4. The reason that one figure is 21 and the other figure is 19% is if someone's symptoms are caused by their cancer and their treatment is curative, you will treat a performance status of 4 patient. So,
but also we're not good at accepting death. So
No.
the patients are desperate for something to be done, whatever it might be. That is a real problem even now, I think.
Yeah, and I think the thing that we forget as well is back when this audit was done, there weren't really very good safety standards. So you might be seen by a junior doctor with 3 years of experience and no oncology experience in a cancer clinic who might determine that you're well enough because you're on treatment. So there were a lot of things that were picked up in this audit that have changed how we do things, including the fact that you need to be on a chemotherapy register to either approve or prescribe chemotherapy. So there were lots of issues. And this isn't just about kind of looking at how we managed the acute issues with patients who went on to die, but picked up loads and loads of problems about the way that we provided a service. And this data kind of came with the bullet point in the report that the NCPOD report supports the Manual for Cancer Services standard that initial clinical management plans for all cancer patients should be formulated within an MDT. And the MDT should be responsible for agreeing clinical care pathways, including appropriate chemotherapy regimens, doses, and treatment durations. It's almost impossible to think nowadays that what we do didn't used to happen. So you'd have individual oncologists making decisions on individual patients without an MDT. Nowadays, the MDT is obviously responsible for agreeing clinical care pathways, but most of our chemotherapy regimens and doses are actually all protocolized. So the MDT wouldn't determine exactly what treatment a patient had. That would be the treating oncologist. But if we wanted to do something outside of the protocol, requires off-algorithm form and the approval of the MDT. So those safety checks essentially are still there. So of all the patients that died within 30 days of chemotherapy for whom there were full data sets, only 85% of patients made it to hospital, meaning that 15% of people died either at home or in a hospice. 55% were admitted to a cancer centre or a centre that had inpatient cancer presence, and 42% under general medicine. And of those, 18% were admitted to a hospital where their cancer care, to a different hospital to where their cancer care lay. And obviously we see that here. We see patients from Ealing and Northwick Park, some of whom may have their actual chemotherapy at Charing Cross, but their care lies with their own hospital. And the Marsden as well is obviously the other big cancer centre in the area. So they looked at quality of care and they looked at a number of indices, including evidence of good communication and actually appropriate management for the problem that the patient was admitted with. And quite shockingly, only found evidence of what they called good practice in 35% of cases. And in 57% of cases, there was identified to be some area of improvement of care. Some of this was around not having established protocols for what we have now. You know, if you've got a patient with neutropenic sepsis, there's a neutropenic sepsis protocol on the intranet. An MSCC patient, there's a protocol. A hypercalcemia patient, there's a protocol. So back when this audit was done, management was very ad hoc. A lot of it was organisational, so around care pathways and patient streams, and a lot of it was both. Really shockingly, in 10% of patients, the care was deemed as less than satisfactory, and that is what would basically flag someone to the CQC nowadays. So one of the outcomes from this part of the data set was that cancer service managers and clinical directors must ensure that there's time available in a consultant's job plan for clinical audit, and also must ensure that time is allocated. So again, this protects the time to look at service and service improvement within what we do in oncology. Also shockingly, some 20% of patients were never seen by an oncologist. And this probably realistically maps to those 18% plus of patients who were admitted to a hospital, either outside of their usual oncology centre or to a DGH in the surrounding areas. So you can see that the majority of patients were seen, not very many within 12 hours. Our current standard is for a consultant oncologist to review all new admissions within 24 hours. So obviously consultant numbers and the way that we work makes it more difficult to review someone within 12 hours. However, if someone's admitted and they're sick as a dog, we will see them straight away. And the NCPOD report came over, presented their data with patient commentary and stories. And these are just 3 of them. And I've selected them to show the spectrum of issues across all areas of care. So not just kind of blaming the acute admission for what happened, but also having a look at where maybe oncologists made inappropriate decisions or that there was a lack of governance. So the first case is an elderly patient with liver metastasis from a lung cancer had received treatment with SACT, which is systemic anti-cancer therapy. After feeling unwell for 2 days, the patient attended an emergency department. The patient had high temperature and a low blood pressure. There was no neutropenic sepsis policy available in the emergency department, and the cancer centre was contacted and a copy of their policy was faxed over. This resulted in a 2-hour delay in commencing antibiotics. The patient was transferred to general medicine 12 hours later and died 6 hours after that. And for that case, the problems noted by the advisors and auditors were there was a delay in seeking advice when unwell by the patient. And nowadays, you'll all have heard, hopefully, of the UCONS hotline. Quite often you'll see entries before a patient comes as far as ED or the medical take with advice from UCONS. So that's a United Kingdom Oncology Nursing Society telephone triage for patients on active treatment. So they all get a 24-hour, 7-day-a-week number. And the reason being is if this chap had phoned on day 1, he would have been told this could be neutropenic sepsis, you need to present to ED. Instead, what patients used to do, because there was no easy avenue to help, is wait, see what happened. I don't feel that bad. If I feel worse tomorrow, then maybe I'll call my doctor. There was no neutropenic sepsis policy in the department. There was a 2-hour delay in starting antibiotics, and then also a delay moving from ED to a medical ward.
Can I just say, so the antibiotic thing, I would hope all of us would do before we call the oncology department. I mean, hypertension, sepsis, and so on. I mean, was that not the case then?
I think it's that you forget you forget that we didn't always kind of know what we know now. It's that whole kind of, when you use medical jargon, forgetting that you know a word is quite difficult and finding a simpler one. I think back in 2006, there wasn't, surviving sepsis wasn't a campaign. There was no general kind of agreement that, door to needle time of an hour for sepsis. You'll see from another one of the cases, sometimes there was no senior presence in a hospital overnight.
Yes.
And decisions would be made on a ward round. So I think we forget how far we've come in quite a short amount of time. Obviously, this was only 2006. And I'm sure that any of the juniors listening would not recognise a world where you didn't give antibiotics to someone that clearly had sepsis, because we've all been taught to think sepsis. Apart from if it's the aorta, then we have to think aorta. So one of the other cases is a very elderly patient receiving chemo for lung cancer. After the 3rd cycle, there was documented evidence of neutropenia. The patient was not reviewed by a consultant, and a further cycle of chemotherapy was commenced. The patient died soon after from neutropenic sepsis. And again, this shows how poorly we used to do things in oncology. So there are many examples of poor management of this patient's neutropenia. Investigation results were not acted upon, and there was no senior review obtained. So this was a case of an SHO not wanting to stop someone's treatment because they were only an SHO and not really recognising the importance of pre-treatment neutropenia. Then the 3rd case is a patient with stage 4 Hodgkin's disease was admitted with a 2-day history of diarrhea, 8 days following their 3rd cycle of chemotherapy. The patient was dehydrated with a very low blood pressure and a raised temperature. The patient was reviewed by an SHO on admission, and a clinical diagnosis of pneumonia was made. 12 hours later, the patient was assessed by a registrar, commenced on intravenous antibiotics and transferred to ITU. So this is that kind of case. I think we forget, you know, how much medicine has changed. Even when I was an A&E SHO, we didn't have a consultant overnight. Quite often there was a trust grade registrar and 2 F2s, and we were the department. The problems noted by the advisors were that there was a delay in diagnosis and treatment of septic shock in a patient with a potentially curable malignancy. And there was a lack of early assessment by senior medical staff. So this junior doctor realised the patient was sick, diagnosed pneumonia, but didn't treat it. So as I said, the report identified failures across the board in staffing, in communication, in the availability of clinical policies and referral pathways, in the use of chemotherapy, sometimes inappropriately, in communication, both with patients and colleagues, in medical management, and the identification and instigation of end-of-life care. So the National Chemotherapy Advisory Group document, which was the second picture on that picture of 3 documents, recommended something called acute oncology. So remember, this was 2009, which was also the year I became a doctor. It was my FY1 year. So I literally have grown up with acute oncology. So it defined what acute oncology was, which is a working partnership between emergency medicine, general medicine and oncology, and pertains to the emergency admission of patients with cancer. Really, really importantly, it also set out commissioning and put an onus on commissioners to provide AOS services in any hospital with an ED. So this meant straight away it became a funded service. What it didn't do really was give very much information on what that service should look like and how to develop a service. And most hospitals, as some of us will remember, kind of were in a position where they had to provide an acute oncology service without any knowledge or guidance as to what that should be. So I remember I was at the Homerton for FY1, and one of the Barts consultants was our AOS lead. And then when I moved to my second hospital, which didn't have any oncology at all, it was one of the hematologists, and they were kind of forced to wear the hat because they'd done some chemotherapy training during their training. So the beginnings of acute oncology were really quite stormy and rocky. Also, with regards to consultants, right at the beginning, when it became more established that it should be a consultant in oncology working within a DGH from a central cancer hospital, it was sort of the thing that people ended up doing at the beginning of their careers. You know, jobs were prostate cancer plus acute oncology, colorectal cancer plus acute oncology. So you tended to see, and this, it will be disrespectful to some of my colleagues, but not to anyone I work with now, you tended to see people that had no interest in acute oncology doing acute oncology because that was the only way to get a job. And I think we felt that right at the beginning. So service development then from 2009 to 2017 was very much a spaghetti junction. Hospitals developed services that they could provide and that worked for them. So the positive in that is that it's developed to your local community needs, but there wasn't really any nationally agreed service models. There wasn't really any joined up thinking, not very much sharing of best practice, and no real clear way on how you move from A to B together without going through 101 different routes. So in 2017, this document was published, which gives clinical advice to cancer alliances for the commissioning of acute oncology services. And a lot of what is there is in earlier documents in some way. The key new outcome measure for us is admission avoidance. So there's admission avoidance. There's a requirement to try to reduce length of hospital stay, to reduce 30-day readmission rates, to reduce mortality within 30 days of anti-cancer therapy. We also conduct 2 national audits twice a year. So one is our MSCC outcomes, and the other one is a national neutropenic sepsis mortality audit. Also to look at patient experience, and also to support patients and clinicians through emergency admissions and presentations of new cancers. The key thing on this, which is different and is flagged, is the admission avoidance. And the key way this document identifies that we do that is via ambulatory care pathways. And quite excitedly, we're having a big refurb at the moment on the 6th floor, where we've now got the whole of the 6th floor. So the orthopedic pre-assessment unit has moved. The chemotherapy unit is moving from 6 East to the whole of 6 West. So we'll have a much bigger chemotherapy unit. AOS are moving to 6 East and we'll have an ambulatory unit. So there is a hope that patients on the post-take that clearly don't need to stay in hospital, but need a bit of a sort, rather than going to a discharge lounge, might be able to come up to us on ambulatory. We'll be able to see all of those patients as well that clearly need a quick eyeball but aren't coming in, as well as being able to provide the assessment beds that we have that are usually used for patients who are clearly going to end up being admitted. It also determined what services are required in which different treatment model. So for cancer centres, there's a retained ownership and an onus on working with acute specialities. So this would be places like the Marsden and the Christie, where actually they do things essentially the opposite way to us. So they employ acute medics, and quite often acute medics with geriatrics and onco-geriatric frailty experience to support them with acutely unwell patients. There are acute hospitals without dedicated specialist oncology beds, and for us that's Mary's, and the model that's described as a liaison service, quite often nurse-led, where we will give advice and guidance, working with acute specialities. And then the Charing Cross type model, where oncology should have retained ownership within agreed protocols, and that's our who we will and won't accept pro forma, working with acute specialities. There's also an onus on really embedding palliative care within acute oncology, because quite often when a patient is sick, it's quite clear that they don't need an oncologist, they need good palliative care. So we are beginning to get our ducks in a row. We're not quite there yet, but we're getting there. So to talk about services at Charing Cross and Imperial, we're a team of essentially 7 consultants. So there are the 5 of us that provide acute oncology input across both here at Charing Cross and St Mary's. So that's myself. There's Mike Gonzalez, who also treats melanoma and germ cell tumours. There's Farah Rahman, who treats breast cancer. There's Waqar Salim, who does radiotherapy for both CNS tumours and some GU tumours. There's Dr. Naveed Sarwar, who treats gestational trophoblastic disease and GU tumours, and myself, and I treat lung cancer. There's also Dr. Williams, who's our MSCC oncology lead. And for Hammersmith Hospital, which doesn't have an ED, so there is no requirement for an acute oncology service, Dr. Ed Park, who's one of the clinical oncologists who treats upper GI cancers and gynae malignancies predominantly, provides an advice service for the Hammersmith site. So how do you contact us? As you all know, AOS registrar at Charing Cross is on 8082. At Mary's, there's the AOS Acute service. So we've got either a nurse practitioner or an advanced nurse practitioner who can be reached by mobile phone. At Charing Cross, we have an outreach AOS nurse practitioner. So if 8082 is busy or held up, sometimes that can be another avenue for review of a patient. Our nursing lead is Becky Joel, and our consultant lead on the acute oncology service is Dr. Waqar Salim. So at the moment, this is who we accept and who we don't accept. So on the whole, we will accept anyone within 28 days of active systemic anti-cancer therapy, with the exclusion of the hormone treatment seen in breast and prostate cancer. It says here immunotherapy within 4 weeks. The caveat to that is, as many of you are realising, immunotherapy can do some odd things at odd time points. So if you have a patient who has a history of having had immunotherapy, so that's mostly all of the MABs, so pembrolizumab, atezolizumab, durvalumab, nivolumab, all of those drugs, then call us, because quite often there can be a link with previous use. I think the longest I've seen somebody had significant problems from pembrolizumab was 2 years after their last dose. So we do see late onset toxicity and issues. We will see anyone on current radiotherapy. The only exception to that is if someone's had a single 8 gray in 1 fraction, whatever's going on isn't related to their radiotherapy. And also we will get involved in the complications of cancer. So new brain metastases, neutropenic sepsis, metastatic spinal cord compression, malignant hypercalcemia not responsive to a bisphosphonate, malignant chemotherapy-related acute renal failure, malignancy-induced bowel obstruction, raised intracranial pressure, superior venous caval obstruction, and ascites or effusion. And the reason all of those are there, and the reason that they would be an acute oncology review, is sometimes, even though a patient is sick, what is going to get them out of the trouble that they are in is reasonably urgent chemotherapy. And the idea of us being involved is that we can make that happen quickly. So things like giving chemotherapy and bowel obstruction is reasonably dangerous, but it works. So these patients are flagged to us so that sensible decisions can be made as to whether someone should be allowed to come out of bowel obstruction conservatively, whether they should have surgery, or actually whether we should be moving in with chemotherapy. So if your patient ticks one of those boxes, then it's a straightforward through to 8082 if it's in hours and the medical registrar on call out of hours. If that patient doesn't tick any of those boxes, we're still here and we'll still come review a patient and give advice. And sometimes a patient might not tick a single one of those boxes, but it's still really, really clear that the best place for them to be is on the sick floor, and we'll come and take those patients over. There are a couple of COVID-19 interim policies that are still working. One of them is for MSCC, which isn't so much of an issue here because obviously we're on the same site, but our MSCC pathway at the moment is treat and return. So if a patient is at Mary's, they should be scanned at Mary's, have an MRI, they will come directly to radiotherapy, have their planning scan, have 8 Gray in a single fraction and go back to the bed in which they came from. And some febrile neutropenias, so there's something called the MASC score that we can use to try to risk stratify how sick someone's going to become. And young fit patients with a low MASC score, we were sending home with oral antibiotics and a daily AOS phone call to make sure they were okay at home. So the caveat to that is common sense. So if you've got a patient who might have had chemotherapy 2 weeks ago, but they've come in a DKA, we don't do general internal medicine. The last time I did any medicine was as a med reg back in 2011. I don't know current management protocols. So there is always a degree of common sense to be used. And we have a really good service with our acute medical colleagues anyway. It's very, very rarely that we end up with a patient that we can't cope with. So referring for an oncology opinion, I thought we'd quickly go over some of this because I think it is quite useful. So it's always useful to know the type of disease, ideally the site, like the primary. Stage can be useful, but not always needed. Grade, again, not really needed. When diagnosed, so if you tell me that someone's living with advanced small cell lung cancer diagnosed 18 months ago, I'm really, really worried about them because they've already outlived their prognosis to a certain extent. Known to which oncologist. Sometimes if you have no clear idea what their cancer is, but you do know who they're under, we can work it out. Their treatment history, and I would argue at minimum the current line of treatment, and ideally the date of last treatment, because it gives us an ability to delineate what side effects they're having and whether they're related to the drug. Sometimes there are specific management steps to be taken based on when a patient had treatment. So if you tell me that you've got a patient with non-small cell lung cancer on docetaxel, I know that they are essentially, regardless of anything else, whether they've got a driver mutation, whether they're a squame, whether they're a adeno, that they're on their last line of treatment. Presenting problem is always useful. Quite often we just get a phone call saying we've got a patient with breast cancer, and that's the referral. So having a question is always really useful. I mean, obviously, if it's I've got a patient with breast cancer, they're neutropenic, and we've given them tazocin and GCSF, it doesn't really need to be a question. I know that's neutropenic sepsis, and I know they're coming under us. But just to state that you've got a patient with cancer isn't very helpful if you're trying to get a good response from us, or for us to be able to provide what you're actually asking for. And sometimes even if it's, I'm not really sure what's going on, but I'm worried, can you help? We'll always come and review a patient. And I guess the point is we might not always accept a case as appropriate for acute oncology, but I hope you all know that we do come down to see the patient. If it's the registrar or the consultant, they'll have some form of senior review just to make sure that the oncology part of their presentation is managed. So new cancer presentations in the acute take. So this data is a little bit old now. It's from 2016, but I don't think it's changed dramatically. So if you look at this column here, these are emergency presentations of cancers, and it probably comes as no surprise that many of those are either cancers that become very acute very quickly, so there isn't really time for the usual diagnostic pathway, and this includes the acute leukemias. Brain and CNS disease, again, it's not really a surprise. Most people go from being asymptomatic to very symptomatic very, very quickly, with previous no indication that there was a problem, to being confused or having a seizure. And I think it would be very, very difficult to ever impact dramatically on those numbers, apart from the services that we've tried to develop in Charing Cross, including having rapid access neuro-oncology, where we have 2 MDTs and 2 clinics a week. And also some of the cancers that we see, like lung cancer and esophageal cancer, and those cancers that are perhaps more associated with lower social economic groups and indices of poverty. Quite often these patients, you know, I can either go and see my GP about my chronic cough, or I can go to work and I can get paid. The cough isn't going to be investigated until it becomes an issue. So I think there are always things on here that we are not going to be able to make inroads into, but there's a lot that we have done, and a lot of these numbers have come down over the last 10 years. So I know that I've just been droning on, so let's try and make it a little bit more interactive now. So if we look at acute and new diagnoses of cancers, how do they present? What do you pick up on your post-take ward rounds or at point of clerking? So I can't see, let me see if I can work out how I can see chat box and my screen. I'm not sure if I can. So maybe
you can. If you move your mouse to the top, a little thing will come down, and then you can see the chat. You can click. You can click on the chat, and then it will appear.
Okay, I'm not getting that.
You move your mouse leftwards a bit.
Oh, I am getting that now.
Yeah.
Brilliant, thank you. More chat. Okay, so you can either shout out or type in chat, and this won't be exhaustive, but what sort of respiratory symptoms concern you when you're clerking a patient in or you're post-taking? Yeah, hemoptysis, that's quite a biggie.
Mm-hmm.
And that seemed to be the theme last week for acute oncology. Persistent cough. Shortness of breath. Yeah. And some of these are all quite vague. It's when you start to see them in combination with each other, absolutely unprovoked PEs. So if we look at the respiratory spectrum, we've got cough, wheeze, shortness of breath, hoarseness, chest wall pain, hemoptysis, unprovoked PEs. Breast, you would be surprised at how many of these do present acutely on the acute take. What sorts of things might you see in someone presenting with breast cancer acutely? And I know I've seen a couple down on AMU. Fungating tumours into the skin, absolutely, and hypercalcemia. And we've had a couple. Yeah, all of these. So, I mean, the obvious ones are lump, nipple change, discharge, skin changes. I remember seeing someone in my first week of being on the acute oncology service as a consultant, referred down by one of the AIM consultants, of somebody who hadn't wanted to be examined but had had a chest x-ray, and the chest x-ray had a really weird opacification overlying the right breast, and I was doing a breast locum, I was doing Farrah Raymond's locum, so went over with a female AIM consultant and managed to persuade her to let us examine her, and she had a huge fungating breast cancer. She also had a unilateral pleural effusion that went hand in hand with it. And I think she just assumed that she'd left things too late and then felt embarrassed about telling people that that's what had happened. She actually had ER positive, HER2 negative disease and started on a drug called palbociclib. And I check in on her every now and again. She's still alive. She's still on palbociclib, and this is some 3 years later.
For lumps, there's a pathway for lumps, isn't there? On the first floor, there's a breast clinic.
There is. So if you've got something that isn't I mean, even with that lady and fungating tumours, we still need to prove it. And our breast surgeons are amazing. So quite often the breast surgeons will come to the bedside and do a punch biopsy if you've got fungating breast cancers or something close to the skin or something that looks like an inflammatory breast cancer. Or if not, we've got a very rapid pathway to get people to the triple assessment clinic on the first floor. We have an amazing breast service. Urinary. So we're looking at things like inability to pass urine, pain on passing urine, hematuria, recurrent infections, absolutely. And then lower GI. And again, these aren't exhausted lists. It's just the things that you see commonly. And commonly these things aren't cancer. So change in bowel habit, blood in stool, abdominal pain, ascites. Upper GI and HPB, swallowing problems, hematemesis, abdominal pain, painful or painless jaundice, ascites. Central nervous system tumours can present in a number of ways: high pressure headaches, personality change, seizures, stroke-like presentations. I think, you know, we've had multiple referrals from medics or from the stroke team with patients who have come in with no cancer history, who have a stroke-like presentation, and their MRI scan is reported with either a solitary or multiple brain metastasis. Upper and lower motor neuron signs. Always be very, very mindful that someone who presents with really odd neurology, so things that don't fit, a mix of upper and motor neuron signs. Are you missing leptomeningeal disease? Really quite common in breast, colorectal and pancreatic, prostate cancer. Skin changes, so non-healing ulcers, masses under the skin, pigmented lesions which are changing. And then some of the other things that we see include bleeding, bruising, fatigue, night sweats, weight loss, and gain. So patients who develop third spacing because of malignancy can gain kilos rapidly. Lymphadenopathy and fluid where it shouldn't be, pleural space, pericardial space, and ascites. So options available. So ED can do 2-week wait referrals directly if it's really obvious where a patient's cancer might be. And my argument for people who don't really need to come into hospital, because sometimes these people do get admitted because people feel nervous about discharging someone who they think has a clear malignancy without an obvious pathway. But with support, 2-week wait referrals can be generated in ED. Admission under the medics with oncology support. So we're about to launch a service called IDOS, which stands for Interim Diagnostic Oncology Service. And the aim will be for patients who are post-taken, where they are well enough to go home, but there's a lot of concern about a clear or likely malignancy, then we will take over that pathway. So these patients don't hang around in a quasi-medical pathway under a consultant that doesn't necessarily look after that area of the body. And we have agreements with all of the diagnostic services, including endoscopy and imaging, that we will get 2-week wait times for anything that we need to get done. We're hoping to go live with this service as soon as we're on the new unit, so hopefully November or December, and hopefully I can come in December and talk to you a bit more about that service. There's also a new vague symptoms pathway, also known as a rapid diagnostic centre, coming online for Imperial. This is an RM Partners funded project in the first couple of years and has been led by Catherine Van Ray, one of the clinical radiologists, and it will likely be a GP-led service. So if you've got patients with vague symptoms that don't fully tick red flag oncology boxes, they can come in under this pathway as well, which will be an outpatient-based service. And it's expected that anything referred to the RDC that looks like it's a cancer will come to us in IDOS, and anything that's referred to us in IDOS that we think is quite vague and likely to be not cancer will switch to that pathway. So there'll be a lot of interaction between the two. Chelsea and Westminster also have their ADOC service, Acute Diagnostic Oncology Clinic, and they're already in RDC. So sometimes if I think a patient is well enough to go home and we're not quite ready here, I have referred patients to Chelsea and Westminster before they're seen within 5 days. And then if you've got somebody who is going to stay in or may be able to go home, then 8282 for general advice and guidance, bearing in mind that they are registrars, they are training, and they may not have done that rotation in that cancer. So you can always escalate to an AOS consultant if you feel, or 8282 themselves feels that this is complex or something that they don't know enough about. So that was really a whirlwind tour of what acute oncology services are and why they exist. And I know it's quite boring, but I think it is quite important. So I can't believe I'm using the word my generation, because I never thought that I would, but obviously I've grown up with AOS as it's evolved. So I've seen it as a working pathway. Those of you that have qualified in the last 5 or 6 years won't have that knowledge. And I think sometimes there is some confusion behind what specialty oncology and what acute oncology is. So I think essentially think of acute oncology as acute internal medicine's kid sister. We're younger, we're getting there, we're growing, we're learning, we're adapting, we're working out our pathways, we're working out national collaboration and how we all work together. And the history of acute internal medicine and the Society of Acute Medicine, I think, is a good blueprint for acute oncology to follow. So that's hopefully where we are. So we're probably around 3 or 4 years behind where acute internal medicine are in terms of getting ourselves properly established and having a clear identity as a separate speciality, but we're not just oncology. Of course, oncology as a specialist subject is also there. And sometimes if you've got a question for acute oncology in a patient that's otherwise stable, and we really don't know the answer, we will suggest that you contact the patient's consultant directly. We've all got good general working knowledge on the acute oncology team, but things change so rapidly that keeping up to date with as much medicine as you can, as well as every single speciality, is really difficult. So acute oncology, I guess, is your little sister. Be nice. So I know that was dry, but I do think it's important. So what I'd like to do now is to try and shake everyone awake a little bit, make it easier to go back to the afternoon. So we're going to play Pokemon or Cancer Drug. So Prof's going to help with a poll. So when we move forward, the options will be A is Cancer Drug, B for Pokemon. I think there's 5 options. It's only going to be A and B. So A, Cancer Drug, B, Pokemon. So the first contender is Verzenio. Verzenio, do you think that this is a cancer drug? Press A in a moment. And if you think it's a Pokemon, go for B. Don't be scared.
So they are voting, and I've got 13 votes so far. Brilliant. So yeah, so what I'll do is I'll publish it in a second. Anyone else want to go? I've got, yeah, okay, I'm going to end it, and then you'll all see that it's 50-50.
Oh, 50-50. Okay, so half of you think that this is a cancer drug and half of you think it's a Pokemon. So it's actually a cancer drug. It's also known as abemaciclib. It's used in the treatment of endocrine naive or metastatic ER positive HER2 negative breast cancer. It's a CDK4/6 inhibitor. This has revolutionized this and drugs in the same class have revolutionized the treatment of metastatic breast cancer. I think from the trial, just for first line, abemaciclib, median overall survival is approaching 5 years, and that's just on this treatment without any of the subsequent treatments that can follow. The reason that I thought I would mention this is its party trick is explosive diarrhea, and it can be hideous. It's usually seen in the first 6 weeks and then spontaneously settles on the whole, but patients can become hideously dehydrated. So it is possible that a patient might present out of hours with complications of being on this drug. You will probably only see them once, as it genuinely does tend to settle. So that's the first one. So Gilotrif, cancer drug for A, Pokemon for B.
Okay, I've got 11 votes, they're coming in. One more, okay, they're all in.
So what do we think? So most of you think cancer drug with the splattering of Pokemon. So yes, this drug is also called Afatinib. It's something that I used to peddle quite extensively. It used to be the first line treatment for EGFR mutated stage 4 adenocarcinoma of the lung. This has now been superseded by a much cleaner treatment called osimertinib. It causes what we call on-target side effects. So on-target means that they're the predictable ones, and it causes rash, mucositis, and diarrhea. And this is an example of the rash that you can see. So it's usually described as an acneiform rash. It's actually a folliculitis, and that's because hair follicles have an abundance of EGFR, and these drugs are not, or afatinib and erlotinib are not very specific for cancer EGFR. So they bind to the hair follicle and cause inflammation. So that's why it's called an on-target side effect. Off-target side effects are those random things that we can't quite work out the mechanism for. So very, very rarely this can progress to Stevens-Johnson syndrome and toxic epidermal necrolysis, although thankfully I've not seen this, but it can be really, really debilitating. Usually it doesn't cause very many problems. I've seen horribly infected rash, I think, once, but it's on a very, very visual part of your body, and it's enough for people to feel, you know, self-conscious and not want to go out. It's an amazing drug, can control people's cancer for many years. But if the downside of that is a rash that means that you can't go out and enjoy the time that you have, then I guess sometimes we don't always do patients the service and the value that we think we are. So Celebi is the next one. So if you think that this is a cancer drug, vote A. If you think it's a Pokemon, vote B.
Okay, 10 more seconds.
So more of you think this is a Pokemon than a cancer drug, although it is quite close, and somebody thinks C, which there's always one that thinks I'm going to go my own way. Well done. So this is a Pokemon. So, and I have this, and no pressure, but my 8-year-old child got full marks on this, largely because he knows his Pokemon, not because he knows his cancer drugs. So Celebi is a psychic grass type Pokemon. It's also known as one of the mythical Pokemons. It has no prior evolutions and does not evolve into anything else. It's known as the guardian of the forest, where it's worshipped as a god, and it wanders through time, visiting various undisturbed old growth forests during peaceful times, leaving behind flourishing grass and trees. And its continuing existence signifies good fortune. Yeah, it's a new generation. Well, it's a generation 2 Pokemon. So I don't know if you'd fully class that, given that we're now at generation 6, but it's one of the newer Pokemon. So Calyx, A for cancer drug, B for Pokemon.
Okay, we're doing well. That's pretty quick. I'll just end it.
Okay. So most of, well, just in the cancer drug window, and it is. So Calyx is also known as pegylated liposomal doxorubicin. It's expensive because it's coated. So essentially this can deliver cleaner chemotherapy. You tend to get less systemic effects because of the pegylated liposome it sits in. It's used in the treatment of Kaposi's sarcoma at incredibly low dose. And in ovarian cancer, it's also got an indication for breast cancer where there are cardiac risks to delivering anthracyclines directly. It's reasonably clean, but you do see hand and foot syndrome and mucositis stomatitis, especially at the higher doses used in ovarian cancer. So Sylveon, cancer drug A, Pokemon B. Yeah. So this is indeed a a Pokemon. So it's one of the super new ones. It's generation 6. It's one of 8 possible evolutions of the basic starter Pokemon Eevee, who of course is Pikachu's best mate, and stuff. Taxotere.
Let's just launch that. Okay.
So A for Pokemon. Oh, sorry, A for cancer drug, B for Pokemon.
%100%.
Excellent, because this is old school chemotherapy, and it felt wrong doing a presentation without relying or talking about any of our staples. So Taxotere has been around since the 60s. It's also known as docetaxel. It's old school cytotoxic chemotherapy, and this is one drug that I am incredibly respectful of. It acts by inhibiting mitotic spindle assembly. It's used in breast cancer, both in the adjuvant, neoadjuvant, and metastatic lines. It's used as a late line treatment of lung cancer. It's used upfront in metastatic prostate cancer and has other indications. So it has a high risk of neutropenia. So more than 30% of patients on Taxotere will develop neutropenia, and all of these patients typically get GCSF if they're on a dose of 100 mg per meter squared or more. So the onset of neutropenia with docetaxel on average is kind of 4 to 7 days, with your nadir at 5 to 9 days and recovery at around 21 days. With subsequent cycles of treatment, then the nadir can extend out. So if you call an oncologist or 8082 and say you've got a patient who's not very well on Taxotere who had treatment 10 days ago, I'm probably not going to be bothered about whether they're neutropenic or not. I've already, they're almost certainly going to be. It also causes peripheral neuropathy. So Taxotere interrupts microtubules, and in order to repair nerves, we need a microtubule network. So people get a stocking and glove neuropathy pretty much in a similar mechanism or a similar way to diabetes. So it starts at the finger, actually starts at the toes. It's usually feet more than hands, starts at the peripheries and works their way up. And the reason for this is that the nerves can't repair themselves. Taxotere or docetaxel interrupts the microtubules that usually transport repair factors for nerve sheaths. So that's why it starts at the feet more often, because that's the furthest away from the rest of the body. So peripheral neuropathy can be really quite troubling. On the whole, it resolves when we stop treatment, but it can be fixed. About 10 to 20% of people can have permanent disability. And when you consider this is a drug we use neoadjuvantly and adjuvantly in breast cancer to treat someone's breast cancer successfully, but leave them unable to do buttons up or to be able to walk. So this is why I state this is a drug that I am really respectful of. And yeah, old school. Okay, Luigia. So A for cancer drug, B for Pokemon.
Okay, 5 seconds.
So 14% cancer drug, 86% Pokemon. I think medics clearly spend too much time playing Pokemon. So yeah, it's a Pokemon, Guardian of the Sea, and it's one of the newer generation mixed type. So it's a psychic type and flying type Pokemon. Apparently it has the ability to calm storms and is said to appear when a storm starts. They're also able to lash up a storm if people have upset them. And that storm can last as long as 40 days. There we go. A bit like the MedReg if you make an inappropriate referral. So Tecentriq, cancer drug or Pokemon? And we're nearly at the end now. So A for cancer drug, B for Pokemon. So everyone said cancer drug. Good. I am actually really pleased because this is a Tessalizumab, and this is one of the newer kids on the block. And this is immunotherapy. So this is an anti-PD-L1 monoclonal antibody, and it's used primarily, this particular PD-L1 monoclonal in the treatment of lung cancer, triple negative breast cancer, and renal cancer. And it can cause all things itis. So essentially, the layman's description of how immunotherapy works is it uncloaks cancer from your immune system. So the drug interacts with PD-L1, enables your immune system to see the cancer and to attack the cancer. And sometimes it can overramp itself and attack other organs. So essentially you can get an itis of absolutely anywhere. The most common are things like thyroiditis leading to fatigue, colitis, hepatitis, and pneumonitis. But essentially anything goes, and there have been case reports, all obviously post-mortem, of people who have essentially rejected their own native hearts because of immune overactivity associated with these drugs. We've now been using PD-L1 therapies routinely on the NHS for about 4 years, and we've got 6 or 7 years of experience of using them in the trial arena. We're getting reasonably good at managing the side effects now, but that's because there's essentially one treatment, which is to throw steroids at it and to get Prof. Miran to come and help. So you can get delayed side effects from these treatments. So this is why anyone within 28 days of a Tessalizumab absolutely ticks a box to come in under acute oncology. If they had a Tessalizumab 3 months ago, as somebody that uses this drug a lot, I'd want to know about it, because it can cause very, very vague symptoms that can be puzzling if you don't fully remember or even know that these drugs can cause problems when they haven't been administered for a long time. So always, always, always let us know about any patient who's ever had immunotherapy. Quite often there isn't anything extra that needs to be done, but sometimes we might notice patterns that we recognise from trial literature or from our own experience of managing patients. So Tepmetko, cancer drug A, Pokemon B. And I think this is either the last one or the penultimate one, I think.
Okay, we're struggling a bit more with this. Let me just show you.
Okay, so the majority, although it's close, think that this is a Pokemon. So let's take a look. So this is a really new cancer drug. This has only been available to NHS patients since September the 13th. So it's also called Tepotenib. It's a TKI and it's used in non-small cell lung cancer for patients harboring a MET exon 14 skip mutation. On the whole, it's well tolerated. I've listed some of the side effects from the patient information sheet. And the reason I mentioned this as well is that it's a new drug. It was available to us on an open access scheme as of the beginning of September. As of last week, it's now going to become a funded option, but Imperial, we got the first patient on the expanded access scheme. So we do have patients on this drug in our trust. Our first patient has had no side effects whatsoever and has been on treatment for 8 weeks now. But on the whole, from looking at the literature, about 25% of patients can get peripheral edema, new onset peripheral edema, that can essentially kind of appear overnight and look to all extents and purposes like an acute decompensation of compensated heart failure. Can also cause fatigue, nausea, some diarrhea, and some generalized aches. For some reason, all drugs used in lung cancer seem to cause pneumonitis, and that's on the list as well. It can cause abdominal pain and constipation. So Articuno, I think this is the last one. So A for cancer drug, B for Pokemon. Okay, so most of you think it's a Pokemon, and indeed it is. So this is also a Generation 2 Pokemon, I think, and it's a dual ice flying type legendary. It's not known again to evolve into anything or from anything. According to legend, it appears before doomed travelers lost in icy regions, sometimes aiding those travelers and guiding them to safety. So you might see it on the 8th floor at 6 o'clock in the morning on a night shift. Who knows? But essentially, that's the end. So what I'd kind of hope with that is it lightened the mood a little bit, but also going over some of the toxicities of treatments that we use. And I just wondered if anyone had any questions for us about acute oncology, about how we work together, about how we develop the service moving forward, because as I've said, it's a partnership service and only works because we have such good integration at Charing Cross between acute medicine and oncology.
That's a really excellent presentation and really compulsory viewing if anyone's not. I think it's really important we all know this. So thank you so much for doing that at very short notice. But it's really, really important.